All right, let's go ahead and get started. Making it back from lunch is always a challenge. So this is kind of the last programmatic session before we shift at the end to the case competition. And incredibly excited to have Aaron McKethan with us today. Aaron's been a long-time friend of the school. He is a double Tar Heel with both his PhD and his undergrad from UNC. He has experience teaching in both colors of blue. So both here at UNC and over at Duke in different roles there. His current role is General Manager of New Ventures at Aledade, and so kind of really interesting work that they're doing that he's going to be able to talk to us around kind of thinking about new business line services offerings, all in this kind of move towards value. Part of why we were so excited of having Aaron kind of wrap things up is that he's going to talk about his journey across healthcare over many years. We talk about kind of the interdisciplinary nature of it. We talk about the public-private partnership. Aaron has not only worked on both the state and the federal side. He also has two startups, Novasci and RxAnti, that helped kind of create, build, successfully exit. So he's a guy who has seen kind of all facets of the system. He's also one that is so committed to our efforts that he and his brother are headed to go deep sea fishing. And he was like, no, I'll wait to go because I want to talk to this group. So he'll tear out of here afterwards to head to the Outer Banks and have some fun. Did your brother make it? Can we acknowledge knowledge?
Well, no, he's not here yet.
Okay, when he comes in, we can all give him a standing ovation or something.
I was going to say.
Let him know.
That's what we should do.
You got to shout him out, right, when he gets here. But Aaron lives in Durham, has 4 kids, and still finds time for us. So, Aaron, let me hand it over to you. Thanks so much.
I appreciate it. Hi, everybody. Happy Friday. I'm delighted to be here back on the right side of town. I've spent a lot of time in dark blue, but I'm glad to be back here. In all seriousness, when my brother arrives, he's tall, he's got a beard, he's going to come through the store. He's a little late. You don't have to stand up. Let's give him a little love. Can you just give him a little love? Not yet, not yet. You'll see me when I point to. I just want to give him a little embarrassment. Let's see what happens. Let's have some fun. And the friends of ours who are already down at the Outer Banks are already sending photos of giant fish that we could be catching, and so we will stick around after, but if you're interested in knowing our fishing report, I will tell you next week. All right, so thank you for that nice introduction, Brad. I'm really glad to be here, and I was thinking about this. What topics are interesting? I was thinking about, from your perspective, I was trying to think about, of all the various things that I've gotten myself into, what would be the most interesting. So I thought I would start by just giving you a little bit of background on me. So this let's see, hang on. I wonder what is she aiming at? Should I aim over here? Oh. Ben McKethan, everybody. There he is. Ben McKethan. That was perfect. Okay. Just as we planned. Thank you. All right. There we go. Okay, hold on. Hold for that. Okay, so this is a little bit of a slide that is not at all intended to imply that my career is worth you focusing on. It is to say, I just want to give you a perspective on how I got to this, to what I'm doing now. Okay, so there's 3. What I realized in creating this slide yesterday is I've been bouncing around between 3 kind of poles in healthcare. First, universities, where a lot of good ideas are developed. I've spent a lot of time in government service at both the federal HHS level and here in our state level. I was the Chief Data Officer for North Carolina's Health and Human Services group, which includes Medicaid and all the rest. But then I somehow, for some reason, kind of oscillate to startups, because maybe it's because now I look at this, it's because I get into the bureaucracy of government and realize I want to go faster. So I've had a couple of companies, which I'm going to spend a little bit of time on today. But you see this sort of spiral. So what does this predict my next thing will be? I'm at Aledade Ventures now. I'm going to talk about that some more. But where does this spiral suggest I'll be next? Any ideas? On a boat? I don't know. As I saw this morning, maybe UNC. I don't know. It sort of spirals back to the university think tank side. So anyway, I'm going to give you a few perspectives on that. I mentioned, and Brad mentioned, that I have been at Duke on faculty in the School of Medicine. And now I'm adjunct there as I'm in the private sector again at Aledade. Again, I'll talk about that in a minute. But I just want you to know, I regard my Duke service as a missionary journey. It's a missionary to a dark blue land. And I have posters in my office. This is not one of them. But I do have a Michael Jordan Sports Illustrated poster on the wall, just so folks over there kind of know what's up. So I didn't want any of you to walk out because you saw the word Duke. By the way, how many of you saw the women's soccer game last night? That was pretty sweet. Beating Duke. Anybody else watch that? You got to go look that up. That was pretty exciting. Okay. All right. Enough of that. So in thinking about this conference and what the topics have been and where you all are headed, I decided that on a Friday afternoon, you might just prefer that I tell some stories. So I've got 3 stories that reflect some learnings along the way of a person who kind of was born a health policy kind of zealot. My PhD's in health policy. I think about how we pay for care. I think about the microeconomics of health care. I think about the choices that people have vis-a-vis the co-pays they pay, the premiums they confront, the way our supply side of healthcare, the way doctors function, but again, I'm also kind of a person who wants to get stuff done. So I'm going to share a few things. The 3 kind of lessons, if they're lessons or more just observations, Story one is about Santee, the company that I founded with some friends who were pharmacoepidemiologists, friends in D.C., and I'll explain why I think that's a relevant story. Part of it is on the combination of how we pay for care and how that mobilizes lots of change very quickly. It's a very highly regulated industry, so government has a lot to do with even the commercial side of healthcare, and knowing that and being nimble creates a lot of new opportunities. We'll talk about Santee. I'm going to talk about what I'm doing now, which is at Aledade. I'll tell you more about Aledade in a few minutes in story two. But that's a story about the illogical logic of what we're doing on the M&A side. I call it illogical because what we're thinking about doing doesn't really make sense unless we're in a value-based care arrangement where we make our money from people not going to the hospital. So I'll come to that in a minute and give you a case study about a company we bought this year and what we're doing with it at Aledade. And then the third is more of a personal one about helping me to process a bit more about what all this work is about. I spent most of my time thinking about data, technology, workflow, blah, 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 policy, but there's often a very different experience when you're on the patient side of that, and I want to kind of close with that. Does that make sense? All right, so 3 stories. Let's start with story 1. Oops, sorry. I'm going to get this eventually. Okay. So how many of you know about the Medicare Star Ratings program, Medicare Stars? Okay. So when CVS's stock price dropped by something like 4 or 5% in a few weeks ago, a big part of the reason was because its asset Aetna learned that its star ratings had dropped. They learned that because CMS, the agency that oversees Medicare and Medicaid, announced the current results of the star ratings. And they had gone, and don't quote me on this, if anybody knows the actual numbers, please raise your hand and let's get them right. But a large percentage of Aetna's members were in 4 and 5 star plans. As a quality scale, 4 out of 5, the highest scale is 5, lowest is 1. There's a bunch of different performance measures that together form that star rating. And for whatever reason, Aetna dropped substantially. And a lot of companies did. It had to do with the goalpost moving a bit. But when that happened, the parent company, CVS's stock price dropped a lot, like a lot. And the point of that story is that, that intro is that in the maybe 10 years ago now, 15 years ago, when CMS decided to start paying health plans that serve Medicare patients on the basis of their performance on star ratings, hundreds of millions of dollars now moved hands depending on how well they're doing on those measures. And it's just so happened that they triple weighted. Somebody in the government decided it would be a good idea to provide 3 times the weight on those measures that are focused on medication use. So if Aetna can help its patients who are taking diabetes medicines actually take those medicines consistently throughout the year, that's where the health effect will come from. That's what the epidemiologists say who focus on pharmacy. You need to take the medicine consistently in order to get the clinical benefit. So if we're spending the money on the medicine, we need to actually take it consistently to get the value. So they structured this star rating program to heavily weight toward performance on these triple-weighted medication adherence measures. There were 3: blood pressure, diabetes, and cholesterol. So there's lots of Americans that take those medicines, and suddenly, overnight, health plans had to figure out, what do we know about adherence? We just pay claims. We don't do adherence. And part of the reason I'm telling you the story is these big health plans suddenly had a big problem. They had to figure out how we're going to comply with these measures to get paid. And beneficiaries that choose which plan they're going to select often use the star ratings as a guide to that. So it's important because they get paid on the measure. It's also important because a lot of their members are going to select the plan as a result of them working on this. Well, it just so happened that I was at the Brookings Institution working on various policy things, and the guy sitting next to me was a pharmacoepidemiologist named Josh who became a friend, and we had meanwhile been trying to figure out, can we predict whether you will take your medicine? That if I have good data on you, on your healthcare utilization over, repeated amount of time, say 2 years, it's not that hard to know, he's the kind of person that will probably take his medicine. He'll probably pick up that refill. And by the way, when we say take your medicine, what we can measure in healthcare is whether you pick up the refill. Can't observe you swallowing the pill. And that's what the CMS measures about, is that will you pick up your refill? But the question we had was, it would be way more valuable if we can identify as early as the first time you take the medicine, whether you are prescribed the medicine, whether you continue to take that medicine. And that's valuable because the way adherence works, the way the adherence world works is basically, before then, was to wait until patients quit their medicine. You try the therapy, you drop off, and then what happens? CVS and everybody bombs you with text messages reminding you to come take your medicine. So our thought was, if we can prevent the discontinuation of the medicine to begin with, that might be better than waiting on all these patients to quit for what they think are valid reasons. And so there was a big policy change, a big policy shock that we had nothing to do with, even though we pay attention to policy, didn't know it was coming. We happened to be working in this area on these metrics for academic reasons, but then we decided, well, let's go talk to some of the health plans and see if we can be useful to them. And so that's the dawn of the company we started called RxAnti. The main initial innovation was this idea of receiving the data that every health plan has on patients, paid claims, and figuring out how to use a combination of good old bootstrap methods and machine methods to predict this outcome. And we could go back in history and prove to Aetna or CVS or whoever that the predictions are accurate because we can back test them with old data. We can say, as of this date, we are going to render a prediction about whether John will take his or her medicine. And it turns out a year later, they did or didn't, dichotomously. And so that was the beginning of it. We didn't have any flashy anything else. We didn't have a data room. We couldn't receive anybody's data. We didn't have any case studies. We didn't have any success. All we could say is we're very confident that this is a prediction problem, not a wait and see and then react problem. And that secondly, that we can predict this outcome. So if we can collaborate with us, we can work on it. Now, there's no reason they should have done that in a normal world because we didn't have any of the things I just mentioned. What we should have done was had proof, evidence, pilots. But because it was such a big policy shock and it's such an urgency to figure out what to do with these triple-weighted measures, there was a lot of openness to collaboration. So I'm going to, the box messed up when I did something in PowerPoint. Sorry, that box up top. Just forget the formatting for a second. Just imagine it's beautiful. It's Friday. Relax. Don't worry about the box. Don't worry about it. Think about the weekend. Okay. So just very briefly, I'm not going to go into incredible detail here, but to say this is the kind of thing that any predictive model should be able to illustrate is that we can predict. I don't know if this thing has a little light. Let's see. Let's see if I break it. Is there a little light on there? I don't know. Probably so, but I'm going to mess it up. Yeah, there it is. So this is the likelihood, probability between 0 and 100 that the model says you'll take your medicine. So 100 means you did take your medicine. And 50 means, I don't know, flip of the coin. 0 means there's no chance you're going to take the medicine. Using this measure, proportion of days covered, greater than 80%. For you pharmacy folks here, you know what that is. The rest of you don't worry about it. It just means dichotomously, yes or no, did you meet the definition or not, and that matters to the health plan. And what we could show is that when we start to predict these patterns, patients that we said had a very high, say a 70 or better % chance of being adherent, we are right pretty well most of the time, 70 or 80% of the time. And what you see is this familiar U pattern, which says, the model says this patient is a coin flip. We don't know if they're going to take the medicine or not at this PDC greater than 80 level for the year. Well, guess what? Naturally, it's a coin flip. We don't know. And this is showing you the same x-axis, but what it's showing you, even though less beautiful formatting, again, sorry, same x-axis, but it's showing us the % of people that are in those buckets. And so it's a number between 0 and 100. I'm bucketing it by tens for the sake of illustration. And these run every day. So if you pick up your prescription today, the model will change because now the probability that you're going to hit the threshold of the year has shifted. And the nice thing is pharmacy claims data are pretty easy to get daily, unlike other claims information. So what this is saying is, all right, well, look, there's a lot of people over here that we said are almost definitely going to take their medicine. And when we said that, we were pretty well right. So just kind of ignore these people. They're okay. If you're constrained in what you can do about it, right? If it's a text message, send the text message. Fine, it didn't cost anything. But we're talking about how do we send humans into homes? How do we send pharmacists? How do we dispatch pharmacy call centers and professionals to talk to these patients to prevent them from discontinuing? We want to be focused on expensive interventions so this becomes an optimization problem. And so what we were working on mostly back in those days, early days, was this group of the patients. These are the undecided voters. So we were based in Washington, so we use a lot of electoral language as we explain this to health planners. These are the people that the days before an election, when you walk into their neighborhood, they don't have a Trump sticker on the back of their car. That's these people. They're already decided. Or whoever Trump's running against at the time, Biden, right? They're already decided. These are the undecided voters, and this was the intuition we had. This is all we had. So would you buy this from us? Probably not. But they did because it was an important moment. So once we started to use this information for health plans, we did develop a data center. We could start to receive and process their claims, and we could pass all the security tests to do that. But what we started doing very quickly was basically optimizing everything they have in their arsenal to deal with this problem. So if they have call center that has a certain capacity in certain markets, we can say, here are the patients that you should be reaching today. If they just had an interview, we could apply a bunch of business rules to it. I won't go into too much detail, but that started to work. And what happened was, does anybody know this children's book right here? Okay, so John, if you give a mouse a cookie, what happens next? He wants a glass of milk. If you give the mouse a glass of milk, anybody know the story? What's the next one? What was it? A bedtime story? Yeah, that sounds right. It's something like that. But this stuck with me. I have a lot of kids. I've got 4 of these kids, so I've read this book 1,000 times. Well, that felt like my life, because we can predict this one thing with humility, right? We can say, I can't do a lot of things. I don't have a lot of things, but I know for sure that I can predict this problem, and I know that this is a problem you have. Well, that ability allowed us to do a bunch of other things. Like we can now say, okay, if you can predict at the patient level, why can't you roll those predictions up at the group level and say, well, how's North Carolina going to do next year on these metrics? And then we can attach that to dollars. Here's how much money you should be willing to spend on interventions for this undecided group of patients in this market relative to the benefit that you're likely to accrue from doing so. So like just that one ability cascaded into other things we could do. This was a fun one that I like to work on, which is, I never thought, I'm a health policy guy, I never thought I'd be talking to call center personnel, but I'd want to know, how many people can you call a day with your best pharmacists? And how are you deciding now who should get the call? And most of the time what you hear is, well, it's patients that have been late to fill. The patients that haven't filled their medicine in the last 2 weeks. We'll just call them. But they're not thinking about it from a predictive standpoint. They're just thinking about it from the most recent thing that happened. And so what we could say is, with that same call center, instead of calling people that way, call them on the predicted likelihood they'll end the year adherent. And so it effectively significantly increases the productive capacity of that call center, because now you're calling the right people. You don't have to add bodies to the call center. You just need to start calling the right people in the right sequence. Does that make sense? And then, the way these health plans operate, the way the Medicare Advantage program is structured, is that Aetna will have 20-some contracts around the country. So it's not like there's an Aetna star rating. There's an Aetna star rating for every single contract, and so they had to decide, how do I apply resources across America in the Aetna footprint, right? Aetna, WellCare, CVS, Kaiser, Cigna, that's the last ones I can remember. There's several of those big, they're all optimizing on the same problem. And then, the last thing we got into was really about, or last thing while I was there before we were required was, how do we get docs involved? Because the pharmacy call center is very effective relative to other things we could do. But getting a primary care doctor to the table to do something about this problem and talking to the patient is actually really effective. It's just that their time is so scarce. Think of that as a very, very expensive intervention from a time and money standpoint to activate it. So those are the kind of things that we did at Arxanti. And then with those questions, we listened to what the questions were, some of the ones I just named, and then we just built tools to help do that. Again, it's not super complicated. It's just the ability to predict that one outcome with a lot of creativity and learning. What is the actual problem the customer is facing? So it's not just, hey, I delivered the thing to you, here's their prediction, good luck. We've spent a lot of time trying to, investigative reporters in these clients, trying to understand, what are you going to do with this information? How can we make it valuable? So one lesson for me as a startup was, don't think that the first thing you deliver is the real thing that's going to add value. It's probably not. It's going to get you in the door, but you need to be kind of part of the team to understand, how do we actually make this thing effective for them? And that's when we built tools to do that. So we've got simulations over here. We could say, if you built a new call center that did this and this and this, could call that many people, here's what that could do for your star performance. Down to the practice level, instead of calling every patient in your panel who has ever taken diabetes medicine, focus on the 8%. Because you don't have time. Focus on the smallest number of patients that can have a yield for you. So this is definitely not rocket science, but it illustrates for me the importance of a shock in the system induced by policy, which we see all the time in healthcare, followed by someone happening to be in the good place at the right time, thinking about how to seize that opportunity before the big incumbent healthcare companies figure this out and do kind of a version of this, and then being embedded with the client to make sure it actually is going to create the value that you want it to. We also worked on policy around this area, or at least try to contribute to the thinking. This is a paper that Ashish Jha, who's now the White House COVID czar. You see him on TV. He's the dean of he's dean of something at Brown, a dean of public health at Brown. We were talking about an experiment we did with WellCare, which was to say, if you're going to pay doctors to improve adherence, which is the thing that you should do, because they're the ones that are most likely to be focused on this topic, you got to make it easy for them. Rather than giving them a pay-for-performance program, you all familiar with pay-for-performance programs? Okay. If you give them a small amount of money to focus on a lot of patients, they're not going to focus on this for you, because even though Ed is a big health plan, it's still a very small percentage of that patient's panel. So you've got to figure out how to make it worthwhile to the practice. But again, going back to the very specific first thing we could do is predict this problem. If you can predict which patients need the thing, then you can spend the same amount of money on the bonus program, but shrink it down to I said 8 or 10% of the patients that actually will make the difference. And now your per patient bonuses are hundreds of dollars, not pennies. So now you get the activation and motivation of the practice, because they can make money to do this. They can participate in the incentive structure of that. So we've been writing about how to think about prediction and payment interactions. So so that's story one. And briefly, the things that I think hopefully are relevant is, as I've said, is that none of that made sense unless the game was changed by policy-driven payment reform. Now, if insurance companies that are on their own wanted to do this, they certainly could. But this company was built on, it wasn't designed this way. We started thinking about predicting adherence because of family members who don't take their schizophrenia medicine. That wasn't anything to do with star ratings. It was like, why don't they take it? What can we predict about the treatment or the patient that would help us get insight as to who we should be counseling and so on. But because of this policy change, all the health plans really want to focus on is this, because this is an existential crisis for them if they can get it right. The second is positive constraints. By that I mean, most of the optimization, the value of the company was driven by the fact that the plans can't do everything. They can't do everything for every patient. So they have to make choices, and what we're helping them do is optimize their resources against the opportunity. And then the third is cascading innovation. There's that point that the first thing we did actually drove a lot of successive products that we offered or modules that we could offer. But that took a lot of learning working with the client to really sit in the client's shoes. It taught me that just because I can get one version shipped of the MVP, the minimum viable version of the thing, trust me, you're not done yet. You've got to work to make sure the problem is actually solved at the very end. But when you earn the trust of that client, they're going to tell you stuff they need that you never would have thought of, and you can build stuff that then you can sell to everybody else. And so today the company sold to a big lab when I was there out on the West Coast, and has since continued this cascading innovation. Now it has a pharmacy, so it's trying to be a full service. It's not just an analytics company. It's now trying to solve the problem and take full risk of the problem. They have interventions, they have a pharmacy, they can talk to the patient directly, and so on. So that's story number one. All right, we'll come to story number two. This is going to require me to take a sip of water, and while I do so, just take a moment and think about what you're going to do this weekend. Okay, story two. So this is fast forwarding to now, I think. Yeah. So this is kind of a similar story. So now I'm at a company called Aledade. Anybody ever heard of Aledade? Okay. Oh, it's like 5. That's good. That's good. Let's make it 7 or 8, maybe. Okay. So the Affordable Care Act. Back at Brookings, the same moment I was sort of thinking about predicting medication use, that was when the days leading up to the Affordable Care Act. And that bill was started bipartisan. It very quickly turned not bipartisan. And there's a lot of things in it that are the main topics in that bill that you hear most about are the controversies around the coverage aspect. Should we cover Medicaid? Should we have these insurance exchanges? What role should states play? Blah, blah, blah. But there were thousands of other pages, right, in the bill. I mean, not thousands, but there were a lot more pages in the bill on other topics, including how we pay for care. And the last panel alluded to the creation of the CMS Innovation Center, which is still around. It's designed, it was afforded $10 billion to test a bunch of different ways to pay. Some of those things have been tried and haven't worked. Others are still going and have evolved. For example, hospital readmission reduction programs. If we're going to penalize you as a hospital if patients come back to the hospital within 30 days, because that stinks. And the theory was it's happening a lot because of inadequate discharge planning and lack of follow-up. So let's ding the hospital if the patient returns within a period of time. That didn't really work that well. The payment model didn't really work that well for a lot of reasons. But there are some of these models have been working pretty well. This hasn't changed. These payment provisions in the Affordable Care Act have definitely not changed American healthcare fundamentally. They're still small relative to all the money we spend on healthcare. But there was the founder of Aledade, Farzad Mostashari, had this. Well, I'll just go to it. He had this. So there's a logo. Okay. He wrote this paper at Brookings, and the gist of it is these few numbers here. So these ACOs. Let me define an ACO. So an ACO is a group of healthcare professionals, provider organizations that take accountability for the total cost of care for a population of patients that they're caring for. This is HMO light. If you're familiar with the HMOs, this is not a patient chooses to join Kaiser and can only go see Kaiser doctors and specialists, primary care and specialists. That's HMOs. This is patients go where they're going to go, and what we're doing is we're attributing patients, or federal government and commercial insurance companies are attributing patients to their primary care provider based on where they actually go. So if you typically go to, Dr. Smith, then the data will say that relationship is between you and Dr. Smith, and what we look at is the pool of patients that are attributed to a certain group of practices or healthcare professionals that are in the ACO. So we look at the total cost of care for that group of people that are connected to the attributed provider, and we predict what the cost will be next year if nothing happens. We have pretty good actuaries around this country, pretty good, as long as you have enough patients in the panel, good enough data. So if we can predict that the cost will go up like this, what an ACO does is if they could come up with stuff that helps lower the actual cost relative to that benchmark, then the ACO gets to share in a portion of the savings. Okay? So it's not changing the per unit price. It's not saying that now hospitals are going to cost X instead of Y, or the drugs are going to cost X versus Y, et cetera. It's rather saying, y'all figure it out. So all of you that are in the ACO, the docs, the nurses, the hospitals, whoever, figure out what would collectively lower the total cost of care under that benchmark, and we're going to share a portion of savings with you. So what Farzad's observation was that might not work that well at all, but it might not work that well, particularly if you have a hospital driving that ship, because they make money on people coming to the hospital. So how are we going to get our heads wrapped around an idea that they're going to keep people out of the hospital to share in the savings that it would have been their revenue otherwise? So just cannibalizing their own revenue, right? But for a lot of political reasons, we needed those we needed models of ACOs that included hospitals. But what Farzad pointed out is that he did a thought experiment. He said, if you have 100 primary care doctors, primary care, they don't deal with hospitals, and there's not a very small portion of total healthcare spending. 5% of healthcare spending, 5 or 6, is primary care. But if 100 primary care doctors, with each of which have on average 2,000 patients in their panel, with patients who have on average $5,000 in spending per year, varies depending on the age and demographics and health status, that's $1 billion. It was eye-opening for him, because the primary care, we don't think of them as the powerhouses. We think of these big health systems that have all the money and the access to capital as the big powerhouses. But his theory was, if we just focus an ACO on the primary care docs, then there's this pure motivation to keep people healthy and out of the hospital. You don't have this dual conflicting incentive structure around whether you should do that or not, right? So this company has this is, I don't love this slide, so I'm gonna own it. I don't love this slide, but what I'm going to draw your attention to is the company's business model. Basically, is we work with primary care docs. We have about 1,300 practices around the country, serving about 2 million patients in I think 40 states now. 7 or 8 year old company. The business model is we're going to provide technology and data for these primary care practices. They don't qualify for these programs on their own, smaller practices, because you have to have a lot of patients in the pool. So we pull them together. We receive all the claims, all the information that is used to help and figure out what's going on with these patients. And then we provide the workflows to the docs and the practice to say, here's the patients that need your attention, okay? So this is not just wait until people show up in the primary care doctor. This is outbound pop health work. This is, here are the patients we haven't seen in a while that have some issue that we need to work on. The way the model works is it's free to the practices. We don't charge them anything. We give them all this. And the business model is, we make money the more lives we have under management. Think of these as dials to turn, right? The more patients in these risk models. And by the way, so I think it's 62% of our lives are in full risk contracts. So this is not just the upside. We'll take a bonus if we do a good job. We're taking risk on the total cost of care, not just the primary care portion of spending, but the total cost of care. Okay, so lives under management times the savings rate. What is it we're able to save relative to the predicted benchmark that's published by the insurance company? And then the share rate, which is how much do we keep relative to the insurance company or the federal government? And that's a function of how much risk are we willing to take. If we're willing to say we'll only take upside risk if we beat the benchmark, they're going to share a much smaller percentage of the savings with us for understandable reasons. But our goal is to get as much share as possible and to take as much risk as possible, which means we have to focus on the total cost of care, right? So these 3 things are dials. We don't own the practices. We're partnered with the practices. We have these contracts with them, and the punchline is this is working so far. This is total cost of care. So these are so primary care is going up. Like, we're calling patients and then bringing them in and helping them triage what they need. But these are the kind of metrics that are proxies for total cost of care. But here's total cost of care reduction. This little these bars are COVID year. It was a weird year for COVID. It's in there, but it's a kind of a weird year. I won't go into it. And I think the numbers are trending to 16, the data I just looked at. So this is working within the company. So every dollar of revenue, and we have $350 million in revenue, and that we have good visibility into 40%. We're still at the 40% growth side of the business, so we're still growing pretty quickly. Every dollar is a function of savings, right? We don't earn fees. We're not charging anybody anything. We don't have an administrative fee that we hide somewhere and the payer pays for it. So this gives us a lot of alignment with the payer, and that $350 million of revenue is net of what the payer keeps. So this is just what we're able to generate. Okay, does that make sense? Company bought. Okay, I can answer more questions about the company, but let me give you finally to the story. Story is, I came last year to start new companies at Aledade, and I had a couple other startup experiences, and this was one where it's kind of a different situation because we have a lot of data. claims and clinical data that we get from the practices. That's hard to find if you're a startup founder. We have 1,300 relationships with practices that we pay a lot of money to every year based on their collective performance. So they will answer the door if we call them. And we have great relationships with payers. So what I'm going to draw your attention to is New Ventures, is the unit I started and run, is we're buying companies and we're building companies that try to help us move those dials quicker, faster than we otherwise would. So those dials, here they are again. So can we get more lives under management? That's a little bit tricky. I'm not spending a lot of time on that. Well, you could buy another ACO, for example. That's one way to grow the lives. But what I've been focused on is this one, the share rate. So here's the stat. We started this company last year. We started the unit last year. Our first company we launched and are launching is called Aledade Care Solutions. This says to an independent primary care doc, we're going to give you access to a whole spectrum of clinical services that are virtual, that are white labeled to you, the practice. So if you have a bunch of patients with a bunch of meds and you don't have a bunch of pharmacists in your practice to deal with that, most practices don't, just refer them to a pharmacist and they'll take care of it. It's free of charge. I'll come back to the free of charge in a second. If you have patients that need interdisciplinary care management and you don't have time to do it, and you only get paid $92 per patient by Medicare to provide that important service, just beam it up to the virtual team that does that all day long. That's the idea. Now, why is it free? It's free because, and the reason we started this business in the first year we started New Ventures is because at our scale now, every 1 percentage point increase in the savings rate that we can generate yields another $100 million in revenue, net of what the payer keeps, what the government or the commercial payer keeps. Okay? So 1 percentage point increase is another $100 million. Getting that up is worth way more than me charging practices for a service. I'd rather just give them the service. If you're a lawyer, we have to comply with all kinds of laws, rules. We do that, don't worry. So we're building this company called Aledade Care Solutions on the basis of our ability to increase the savings rate relative to what the practice can do on its own. They're capacity constrained, staffing is challenging right now in healthcare, and we're augmenting their capacity. But the revenue is run through the ordinary Aledade care model, the Aledade business model, right? We don't need to charge a bunch of money per unit. That's the fee-for-service structure we're trying to augment with value-based arrangements, right? So this case of Iris is a company that we launched, Aledade Care Solutions. North Carolina's Secretary of Health and Human Services, Mandy Cohen, we recruited her to join and be the CEO of this new company we started last year. So she's leading that. And we bought this company called Iris Healthcare to be one big part of that unit. Iris is a company that is provides that we've worked with with a randomized control trial over 2 years to study are there cost savings in delivering comprehensive advanced care planning for patients nearing the end of life, so their wishes are honored and their doctors know what they actually want to do in healthcare, like with various scenarios. And that's a company that we didn't invent, but we've been partnering with. We studied carefully, and the good news is they were trying to charge payers hundreds of dollars per completed intervention. But we, through our trial, learned actually they should be charging more if they deliver this to the right patients, because the savings are thousands of dollars, because most patients don't want to do all the stuff at the end of life, turns out, that we do to them, right? So if we just let them express their wishes, you can avoid a lot of unnecessary utilization that the patients themselves don't want. So we decided to buy Iris because we wanted to go from a few hundred of these in our trial to tens of thousands across the Aledade network. And the way to do that is to cut off any distraction they would have and to really pour the gas on this. So I speak of this to say there's an seemingly illogical investment decision here. Our M&A is driven by savings. It's not driven by standalone revenue. In fact, when we bought the company, the first thing I did was cancel all the rest of their contracts, which were making money for us. Why? Because I want all that capacity to go to patients that we can get significantly more value from and increase that savings rate and really drive the success of of Aledade Care Solutions. And we're going to have other programs, we're going to buy other things that meet this criteria. They may not be great fee-for-service businesses on their own, but they're fantastic in a risk model where we're rewarded on savings. We're developing a bunch of new things, but we're also looking at our M&A strategy is really focused on what's the next Iris that we can bring in and have an instant scale to this. So similar incentives, similar takeaways. This started with the payment model. None of this works unless we're not accountable for doing more services at higher intensity, which the fee-for-service system is designed to produce. But if we're actually focused on health and total cost of care, we can be very creative about what we're trying to do. If it helps patients keep out of the hospital, if it's good for patients, and it's safe for them, and we can deliver it at scale, then we'll do it. Evidence was a big part of this. I wouldn't have canceled all those contracts. We wouldn't have paid what we paid for the company if we didn't have a lot of confidence, not just in some kind of a slick marketing material from the company, but actually we worked with them in a randomized trial that we oversaw. It gave us the investment confidence that we need to make big decisions about how to scale that. And then the fact that we have doctors who, for many of whom, get a third of their revenue now, these primary care practices, from these value-based arrangements with Aledade. They trust us. And so we can, and we're integrated into their workflow. So we can now say, hey, Dr. Smith, this is a patient that will benefit from this advanced care planning. They can refer the patient in a way that produces much higher return than if Iris calls them directly without a relationship. So that's, we can say more about Aledade. I realize I'm going a little long. So let me finish my final story after taking another sip of water. All right, this one will go faster. So should Dad go to the beach? So I've spent my career, as you saw in that little Candyland journey at the beginning, thinking about data and policy and technocratic stuff, the details of healthcare, and that's a big part of what healthcare is about. How do we pay? Who do we pay? On what basis do we pay? And who has access to what data? That's been the constant focus of my career. But it's easy to kind of assume away all those technocratic details as the most important stuff. So my brother and I, didn't tell you I'm putting this in here. I've also been thinking about like what actually matters to patients. You know, what do they care about? This is a paper we did before our dad got sick, and I'll tell you about him in a minute. But it's just to pause and say we have all these quality metrics. Remember the star ratings program I told you about? There's 53 some odd measures, at least back then. It may be more or less now. There's a lot of measures that you have to comply with, and they're all good measures. If you read the definitions of those measures, you think, yeah, that's good. We want to see patients with diabetes get good diabetes care. That's the measure. Patients that have this or that get this or that good thing. That's the gist of it. But what we don't really do systematically is ask patients, what do you want? What are your needs? What would make your life better? So back in 2015, our dad was diagnosed with stage 4 lung cancer out of the blue. And, well, not quite out of the blue. He'd been a little bit sick. We couldn't figure out what was going on with him. And the experience that we had with him in the medical process, super compassionate doctors and nurses, high quality of care, no complaints. But here was the puzzle. When he got this really bad diagnosis, they kind of said, prognosis is not great. Stage 4, it's a pretty aggressive cancer. But they couldn't answer the simple question that I wanted to know. And I'm thinking, I've spent all this time in data, but we can't answer this question. The question was, all right, we're going to start this chemo. Should we do the chemo? Even though the prognosis is not good, what's the likelihood this matters to him? How many patients like Dad, get this chemo? And of those who get the chemo, how long are they sick after that? What's the deal with that? Like, can we just tell us about the typical experience for a very common, I mean, think of this. He's a white man. We have a lot of white men in this country who have cancer, okay? It's lung cancer. It's a very common cancer. He's on Medicare. We got a lot of Medicare patients, a lot of data that could help us inform this. But no one could answer the question, what percentage of patients are still alive 3 months later, would have recommended that chemo? Like, we have nothing to go on. And again, great doctors, great nurses, called a lot of people around the country that I knew in the oncology world, and they would point me to a study that was done in like 1997 with this group of patients and so on. But I couldn't believe it. Like, this is not a complex prediction problem or a causal inference question. This is counting. How many patients that look like this, have, this age, this kind of cancer, this demographic, also look like this? And the best they could do was, help me know what their last few patients saw. So there's like a recency kind of bias. And I don't blame the people. I just think, how do we engineer a system that has so much data involved to not be able to answer very basic questions? And why did it matter? Because Dad's brother, Uncle Gene, was down at Holden Beach, and he was being treated for radiation. He was being treated with radiation for prostate cancer. He was fine with prostate cancer, but he had to be there every day. So the question was, we're trying to get Dad to the beach to spend a summer with his brother. Is it worth it to do this chemo thing? Is he going to be in the bed all year? Is he going to be in bed for 2 weeks? Like, help us know that. And everyone was trying to help us think about it, but it blew me away that that's how our system works. We're not organized that way. Jane, who's in the last panel at Blue Cross, they have the data in their data warehouse that could be compiled to answer questions like this, right? We have lots of pools of data, but we don't have them organized around things that matter. So there's Dad and Gene, and the answer is yes, he did go to the beach. This is Dad and Gene at the beach that summer. It was a fun summer. It was a hard summer, but it had me thinking more about all this work around data and data flow and incentive design and all the rest. And that's the question that mattered to Dad was not, is this going to save me, and what's the survival rate and all the detailed things that are hard to measure. Just how many people get this? Yes, no. Like, how many get it? How many could be able to go to the beach, a few weeks later? So lesson from that story is that counting is harder than we think. It's actually really hard. I could also share some stories from my days in at DHHS, where we have all kinds of data on everything. But there's just a bunch of basic counting problems, like what percentage of opioid use disorder, patients diagnosed with opioid use disorder are getting clinically indicated treatment for that. That's super hard to answer. And that's not prediction. That's not sophisticated anything, right? So we can make businesses out of this. We can create companies out of this. We can be better at counting numerators and denominators. Then we can predict stuff, and we can use machine learning for all the fancy stuff. But we've sort of overlooked the basics. Empathy and listening to what the patients really want is really important. It's hard to do because we want to fill out our EHR with a bunch of checkbox things, but listening is hard. We're overwhelmed with computers and machines and information that we have to push to participate in. But listening and empathy produces gratitude, and in that case, the efforts of the team to help us answer that question built trust, so that next time they said, we really need you to do X, Dad's more likely to do X, even though it didn't feel good. So this isn't just a one-hit wonder. It's really important to build that in. So thanks for letting me end on that little personal story. So 3 stories. Hopefully something in there is useful to you as you think about all the cool topics from today's conference and your own work and your own careers. So let me stop there and thank you very much for listening.
We do have time for a few questions.
My brother may ask a question. John, you can just project.
Any X and T.
Yeah.
All right.
Yeah.
You allowed to do experiments.
Mm-hmm.
So how do experiments
Yeah.
patients connecting with the ethics of the health?
Yeah. Yeah, so we can do things, well, depending on the client. These were such important metrics. An experiment requires a control group. A control group is somebody who doesn't get the thing. And there is a push to give everybody the thing and hope it works. So it was challenging. But the kinds of things we can do with clients would be things like, okay, we just said we're going to optimize this pharmacy call center. This patient has a lot of meds. They're going to need a lot of calls. So let's try to give the same patient the same caller every day. Every time they get a call, it's Sue, rather than some random new person that doesn't know them. Does that relationship help? So we measure a sequence of those kind of repeated calls with Sue versus the usual whoever's up in the queue calls Sue that day, right? Those are the kinds of things we could do. And we could do some block randomization of phase-in of things. Like we're going to start here on this state. We're going to turn this program on in this market. We're going to turn it on in this other market 2 months later. And that gives us 2 months of control, difference there. So there was openness to it, but it is really hard to do it. There's a really good stat article that just came out with the author named Matthew Herper. I commend it to you. It's really, really good. It came out like 2 days ago. And he's talking about the challenge of randomization in healthcare, because we're doing all this fancy stuff, but if we could just actually focus on randomizing, we'll learn so much so quickly, and this impulse to do more and not have a holdout group, because we can't have any, So it was an uphill battle. Never anything, John, that's I would say major, like withholding any kind of treatment from somebody. Is like, if we have this much money to deploy this in 2 markets, let's be smart about how we deploy it, that kind of thing. Less real clinical trials where you need a bunch of patients to decide if they should participate or not. But I think that's really important that we do that. Yeah.
How are you handling the challenge of the underserved community, underrepresented community, certainly here at thousands of them?
In both companies, or in one particular?
Both.
Yeah. So the good news is the government